Dr. Kelly, I hear your Irish accent. I don't know if you're a fan of Texas football, but the Texas Cancer Interception Center is probably the most Texas title you can have for football with an interception in the title.
Well, I'm a huge Cowboys fan, definitely a big NFL fan. 40% of Americans will hear those words, "You've got cancer," in their lifetime. Cancer will overtake heart disease as the number one killer of Americans in 2030. So they're the stark realities, but there's good news as well. We all hear the news about more and more people getting diagnosed with cancer. But what if we could add 5 words to those words, "You've got cancer"? If we could add, "But we found it early." People will say, well, don't we screen for cancer in the United States? The answer is yes, we do. But we only screen for 4 real cancers in the US. They make up about 28% of cancers. So that means we've got about 72% that we don't have any screening for. And no one knows they've got these cancers until they start having alarm symptoms, which are, gosh, I don't feel well, or you've got blood in your urine, or you're having difficulty swallowing, or you feel a mass under your arm or in your groin, or you're losing weight. That's what we call alarm symptoms. How do we break that if we don't have screening? And that's where we're going with the Texas Cancer Interception Institute. There's a whole raft of new tests emerging that we need to start getting ready for. Some of them involve blood tests, some involve testing at home. That's the way I think the future of cancer detection in America will be. But we formed this new institute to get ready for this whole new era of cancer detection. Then if we can do it that way, we can start empowering people to test on a much more frequent basis, maybe on an annual basis, as part of an annual workup of blood tests, or even at home. And you can see now where I'm going with this. How do you make it easier for patients across the US to do this, when and where they want, when they decide they want, and can we even do this via their smartphone? We do everything else in our life via our smartphone. Can we start ordering these tests? Can we start doing it at home? And can we break down barriers that have made it difficult to test so everyone feels that they can check much more frequently? We do that, I think we'd be in a better place. We'll probably detect more cancers and hopefully will result in many more long-term survivors.
This is Genetics for Healthcare, a podcast for patients.
This is Genetics for Healthcare, a podcast dedicated to patients and their caregivers to help advocate for a precision medicine approach to their healthcare, which includes disease treatment, screening, and prevention. You can find us at geneticsforhealthcare.com. And while you're there, connect with us on your favorite podcast app, Spotify, Apple Podcasts. You can also find us on YouTube, LinkedIn, Facebook, Instagram, and TikTok. While you're there, hit the subscribe button, especially on YouTube, to get alerts on new episodes like this one. Now, here we talk to you guys a lot about genes and their importance to know when you've been diagnosed with a disease like cancer or cardiomyopathy or other rare diseases. You can have those conversations with your care team, your doctors, your nurses, and even your family members, and to be a better advocate for yourself to ensure genetic and genomic insights are considered for your care. Now, there are multiple tests. We're not talking 23andMe here, but there are multiple tests that will help your clinicians identify genes that can improve your chances of conquering and beating cancer. These tests are widely available, but the data shows that few people are getting the tests. And one of the reasons might be is that there are few institutes that are actually dedicated to leveraging those genetic and genomic insights to treat your cancer early, to intervene as early stages as possible that increase your chances of beating cancer and ultimately preventing it, either for yourself or future generations. But we can't say that anymore because today I have Dr. Ronan Kelly, Executive Director of Oncology at Baylor Scott & White Healthcare System in Texas and Executive Director of the Texas Cancer Interception Institute. Dr. Kelly, thank you for joining us on Genetics for Healthcare.
Oh, thank you for having me. Real pleasure to be here. Thank you.
Okay, so Baylor Scott & White is a huge system, and I mentioned this before. There's many hospitals that have genetic counselors. They have the professionals that will help patients have conversations about genetics, or they may be testing BRCA or for Lynch syndrome, which is fantastic. But there are very few institutions connected to hospitals that are dedicated to leveraging these insights to change the way we do things. How did you think about this, and what was your vision for creating the Texas Cancer Interception Institute?
Well, let's just step back for a minute if we can. Let's look at the big figures, okay? 40% of Americans will hear those words, "You've got cancer," in their lifetime. Cancer will overtake heart disease as the number one killer of Americans in 2030. So they're the stark realities, but there's good news as well. We all hear the news about more and more people getting diagnosed with cancer. But what if we could add 5 words to those words, "You've got cancer"? If we could add, "But we found it early." See, that's the key here. If we can detect cancer earlier than ever before, then we give people a really good chance to be a long-term survivor. We all know friends and family and loved ones, unfortunately, that have passed away from cancer. A lot of the time, when they presented, they had quite advanced disease. And that's what we're trying to break that. Can we actually diagnose this disease much earlier than ever before? Now, people will say, well, don't we screen for cancer in the United States? The answer is yes, we do. But we only screen for 4 real cancers in the US. And there's lots of more cancers just in these 4. As you know, women screen for breast cancer with mammography. Men and women screen for colonoscopies or for colon cancer using colonoscopies. Then again, women screen for cervical cancer with pap smears. And then former smokers screen for lung cancer with low-dose CT scans. But very few of our population that are eligible for low-dose CT scans actually ever turn up or even know about that. They make up about 28% of cancers. So that means we've got about 72% that we don't have any screening for. People are sitting at home and they know these cancers, pancreas cancer, ovarian cancer, stomach cancer, I could go kidney cancer. You could go on, bladder cancer, et cetera, et cetera. We don't have any screening for these. And no one knows they've got these cancers until they start having alarm symptoms, which are, gosh, I don't feel well, or you've got blood in your urine, or you're having difficulty swallowing, or you feel a mass under your arm or in your groin, or you're losing weight. That's what we call alarm symptoms. How do we break that if we don't have screening? And that's where we're going with the Texas Cancer Interception Institute. There's a whole raft of new tests emerging that we need to start getting ready for. Some of them involve blood tests, some involve, testing at home. That's the way I think the future of cancer detection in America will be. But we formed this new institute to get ready for this whole new era of cancer detection, which is not just relying solely on imaging. We've looked at x-rays and CAT scans and mammograms or colonoscopies. How do we do this using what we call circulating biomarkers, which are basically a blood test or a cheek swab or a urine test or a stool test? That's the future, because then if we can do it that way, we can start empowering people to test on a much more frequent basis, maybe on an annual basis, part of an annual workup, a blood test, or even at home. And you can see now where I'm going with this. How do you make it easier for patients across the US to do this, when and where they want, when they decide they want? And can we even do this via their smartphone? We do everything else in our life via our smartphone. Can we start ordering these tests? Can we start doing it at home? And can we break down barriers that have made it difficult to test so everyone feels that they can check much more frequently? We do that, I think we'd be in a better place. We'll probably detect more cancers and hopefully will result in many more long-term survivors.
Okay, you just said a lot that I want to make sure that we unpack there and double click on one of those things. You mentioned smartphone that made my antennas go up. So you just mentioned we're closing in on 2 million new cancer cases every year in the United States. There are upwards of 18 million people who have either conquered cancer or living with their cancer. And we still today only have screening, as you mentioned, for only 4 of those cancers. So your institute emphasizes expanding access to these advanced technologies, which you just mentioned. What kinds of tests are available now that weren't available a decade ago, and how do they help detect cancer earlier?
So I want to be clear. Some of what I'm talking about, in fact, a lot of what I'm talking about is on a research protocol, right? So they're not FDA approved or they're not available all over the US right now, but things are beginning to change, okay? Just keep that in the mind when I'm talking about where artificial intelligence will bring us, where I think a lot of these new assays and tests will bring us moving forward. But right now, if you look at the landscape, as I've mentioned, we have mammography, we have colonoscopy, we have low-dose CT scan, we have pap smears. Men have also been able to do a blood test called PSA testing, as you're familiar with, for prostate cancer. We don't really have skin testing for melanoma on a national basis, but you're told if you have a suspicious, skin lesion to go to a dermatologist to get that checked out. That's really where we are. Now, entering the marketplace are blood tests. Blood tests that are called multi-cancer early detection, or MCED. That's what multi-cancer early detection is. It's a blood test to detect cancer. Now, these tests are designed to be able to pick up those other cancers that we don't have screenings for. So those ones that are sitting in our abdomen, like I've mentioned, like a ovarian cancer or a pancreatic cancer or stomach cancer. If we can start to detect people who have these cancers earlier, the hope is that we may get those patients to surgery much quicker. And we know if we can get you to surgery when it's a less advanced, less invasive, less aggressive cancer, that you have a better chance of a long-term survivorship. There's one test on the market currently, a blood test called Gallery, which is entering the space. It's being offered a little bit right now through concierge medicine because people have to pay out of pocket. It's not covered by insurance. It's not FDA approved, but it is available because it's what's called a lab-developed test. And we've seen, certainly in the Dallas region where I am, a number of patients taking that test. There's another one which is just about to be released in the next few weeks called Cancer Guard, and people will start hearing of these blood tests now. They're really aimed, Rome, for patients between the age of 50 to 80. We don't want to be testing a general population of college kids because, so few of them are getting cancer. But as you know, as you enter your 50s, your chances of cancer starts to go up. So these tests are really aimed at that patient group, the 50 to 80-year-old, no prior history of cancer, who does physical annual workups. Could this be part of your annual workup? The way I explain it to some patients is, can you get checked for your cholesterol or your lipids? Could you start to think about a blood test to detect cancer when you start entering your 50s? The tests aren't perfect because they're only we're starting on this new era. The sensitivity is how sensitive is the test to pick up the cancer, and the specificity is if the test tells you there's cancer, how true is that? That's really what we're looking at. But these tests are additive because we don't have anything for, as I said, ovarian, pancreas, stomach, etc., etc. Let's consider exploring these additional blood tests on top of the current screening modalities. We don't want anyone who would ultimately be also due their colonoscopy not to take their colonoscopy because they've had one of these blood tests. So that's where I hope this will go. The tests will get better over time. There's no question that the science will evolve. The ability of the test to detect small, less invasive cancers will get better. Right now, it's able to pick up those bigger ones. What we're really doing is we're looking at circulating tumor DNA. And you might say, well, what's that? The way I describe it is when you brush your hair, some of your hair comes out on your comb, or if you get a bad sunburn, some of your skin starts coming off. Think about it like that, but on the inside of your body, tiny little pieces of the cancer, if it's there, are shedding off into the bloodstream. And we now have the ability to detect those little particles that are shedding off into the bloodstream. The cancer's not breaking up. It's just tiny little pieces are coming off, like brushing your hair with a comb. We can now detect them. We can detect them in patients who maybe not have any symptoms. So they get a blood test as part of an annual workup. If it's positive on one of the tests, we follow that up with a CAT scan to see if we can identify if there's a tumor there. So I think this is where this is beginning to move. This is what I call this new era of cancer detection, where it's circulating biomarkers. For your listenership, circulating biomarkers are things circulating in our bloodstream, but they may be detectable in other bodily fluids in the next couple of years, potentially as a urine test. Everyone has already heard probably of those ads that we see on NFL Sundays, the Cancer Guard, which is a stool blood test, a stool test, where in the comfort of your own room, bathroom, you can give a stool sample and they can check it. This is where it's moving. The ability to detect cancer from at-home tests or tests at your primary care level on an annual basis to try to detect cancer and try to keep ahead of it.
That's a fantastic analogy, by the way. I don't have any hair, but I'll always remember that and use that myself. When you're combing your hair, some of your hair breaks off. So I remember that. Your institute aims ambitiously to cut cancer deaths by 50% in the next 25 years. which echoes the Cancer Moonshot Initiative. Dr. Kelly, it's one thing to identify the people who are of high risk. It's another thing to integrate these multi-omic data points into the healthcare ecosystem to make it predictable, actionable, accessible when it's needed. What are the biggest obstacles to doing that? And how will genetics become more accessible if we're able to do that?
Yeah, well, to answer, part of your question right there, first of all, that's not the aim of the Institute. That's actually the United States aim, because we now have a new national cancer plan. And the aim of the National Cancer Plan is decrease cancer mortality by 50% over 25 years. Now, how do we do it? The only real way I think to do that is early detection. I think everyone would agree. If we keep waiting for people to present with alarm symptoms, like I've mentioned, we're not going to bend that mortality curve sufficiently. What we need to do is go into all parts of the United States and empower our citizens to start testing on a frequent basis. And hopefully if we do that, we'll break that stranglehold cancer has on our psyche where we're afraid, of getting cancer. But if people feel like they're testing on a more frequent basis, hopefully we'll be able to detect much more cancers. 2 successive governments have come out. You mentioned the Cancer Moonshot Initiative, which we heard from President Biden, which again was early detection and using new technologies. And then from President Trump's administration, we heard of Stargate right at the very start of the administration, which was, again, can we use blood tests to detect cancer, and can we use the power of genetics to start trying to think about vaccine development? So I think what we're doing in our new institute is we're really just getting behind our government's goals here for the United States. And if we can do this in the biggest state of Texas, we can do it anywhere. So we've called this the Texas Cancer Interception Institute, which is to really break down barriers to testing, to bring it into the population, and to show the United States that we can do it right here in Texas. And the lessons that we're learning in Texas, we can transport all over to the other states, because we're looking at rural areas as well as urban areas. We're looking at different socioeconomic backgrounds, different racial backgrounds. Let's start empowering people that here before have been a little afraid to go for their tests. Like, you take a farmer in, say, rural Texas, and his wife is saying to him all the time, go for your colonoscopy, go for your colonoscopy. There's a reason why, some of these guys don't turn up for their colonoscopy, because they're busy and they've got a job and they can't leave the farm, and it takes a day, to go to the hospital and to take all the bowel prep. What we're trying to say is, let's start thinking outside the box. Let's start giving these individuals who have been a little bit reluctant to go for their colonoscopy. There's now a blood test, for example, that's available for colon screening. It's called Shield. If you look at, colonoscopy is still the gold standard, but if the person won't turn up for their colonoscopy, let's at least give them a chance to do something different. And if we could offer them a blood test, maybe if that's positive, then they'll come for their colonoscopy. That's the way I want us to start thinking about this. If we keep thinking about doing the same things over and over, mantra we all hear from our mums and dads as we grow up, do something different. Give people another way to look at this. And I think if we could offer someone a blood test through their primary care doc, if they won't do their colonoscopy, maybe then they'll turn up for their colonoscopy if it's positive. And that's the way we're looking at it. We're looking at all these different assays. I've mentioned now a couple of them that are on the market. These multi-cancer early detection blood tests. They look for 50 different types of cancers. Or maybe it's a single blood test for one cancer, which is what that Shield blood test is, just for colon cancer. And they're coming now in waves. There's a lot of these tests entering the market for all different cancers. We're seeing data. We may be able to detect bladder and kidney cancer from a urine test. So let's start thinking about what the next 5 years looks like, where we start breaking down barriers so that everyone in the US feels empowered to test for cancer on a more frequent basis. I just think that's the way forward. In a few minutes, we'll talk about where artificial intelligence will bring us. But these new blood tests or urine tests, you mentioned 23andMe, I think, at the very outset. The ability, a lot of people have been doing Ancestry.com or 23andMe at the holiday season. Now we can do that on a medical basis. We can start to determine who's high risk for cancer based on their genetics from a simple cheek swab. So what we're going to be doing in the Texas Cancer Interception Institute is start sending people cheek swabs to do at home. And then if they have a positive finding through their smartphone, we're going to engage with them through a genetics counselor who can then show them what they have to do, so they don't even have to leave home in many instances. And I think that's the way we're used to doing that. Like, your listeners will do a lot of their day-to-day lives on their smartphones, right? Could you imagine if we started offering them an ability to seize control of their health, to empower them to live well, by breaking that stranglehold and hopefully being able to order tests at home. And then if they have a positive finding, they will not be left on their own. We're employing navigators to hold their hand. We'll have nurse practitioners. We'll have genetics counselors. And very often you can communicate with them in many different ways, either through a text function, which is what a lot of us like to do, or via email, or a virtual call through Zoom or Teams or whatever your preferred video chat is. Or then the final one would be come in and have that sit down face-to-face visit. I hope people will understand that's a new way of trying to do early detection on a way we've never tried to do in the US before.
Okay, so a little bit of a two-part question. First of all, I want you to get, and I maybe should have asked this at the beginning. Tell us about the Baylor Scott and White system. What's your catchment area? How many patients you guys see through your cancer center? I'm going to ask you a follow-up after that.
Well, so the Baylor Scott and White health system is the largest not-for-profit health system in Texas. So we have 51 hospitals across a geographical footprint ranging from the Dallas-Fort Worth Metroplex, so Dallas over to Fort Worth, down through central Texas, and then into the Austin marketplace. And now recently we've signed urgent care deals in Houston, San Antonio, over to Abilene. We're looking at a very large footprint, which is rural and urban, as I said, one of the largest health systems in the country. So the lessons that we're learning here, we can show other health systems to do because they can replicate what we're doing. We're taking the lead. We called it the Texas Cancer Interception Institute on purpose because we want all of Texas to get behind this. We're talking, actually, I won't mention with companies, but with sports franchises, with airline companies, with IT companies. We want them all to get behind this. And we want to start using social media. Very often men, you and me are men, we're afraid of our healthcare. Women sometimes can be more forward than we are. We've got a lot of guys that sit back and they don't want to do it. How do we break that stranglehold to empower men and women to start testing? Because I think we can do that. If it's sports stars or if it's, a big business or IT, let's have new ways to try to break that fear that we all have about testing, because if we can diagnose things earlier, we can help a lot of people. A lot of us are afraid, we're like, well, what if they find something? And I'm very cognizant of that. I don't want people to think for 1 minute that I would underestimate that. What we want to do is change the way we do this and make it easier on a patient-centric, care everywhere approach, which means the patient decides when and where they want to test, how frequently they want to test, and then if there's a positive finding, someone holds their hand all the way through this journey. And you could imagine we're talking about something creating now for an industry first, virtual cancer diagnostic journeys. When you touch a smartphone on the app, on the My Baylor Scott and White app, all the information will pop up. It'll say, this is what your test shows. If it's a positive test, you're not going to find that out on your phone just by accident. A doctor will call you. Your whole journey will be mapped out. Where am I going for my CAT scan? If my CAT scan's positive, when am I seeing my surgeon? And all these pieces can be added in on a time scale. When you just open your phone, you'll be able to see it. If you have any concerns, as I said, you may be able to text a question, or you can have a video call, and then finally that traditional face-to-face. So a lot of this is when the patient wants to do it. I hope you agree, if we make it easier for people and we take away some of the fear, then I think we'll really help a lot of folks.
So I want to make it clear to our viewers, I don't have a vested interest in Baylor Scott and White. This is not a commercial, but here's the reason why I'm so excited to have this conversation, Dr. Kelly. You and I cross paths because I've been working in this industry that we call precision medicine for a couple of decades, and my career and everything that I've done on the industry side has been dedicated to helping patients get access to this information. And the frustrating thing has always been is that genetics and genomics, in many cases, when we're talking about cancer care, in my experience, has been the last thing considered. Well, out of standard therapies, let's run this test and see if there's anything out there. And even though this field has grown, there are much more targeted therapies. There are much more diagnostic tests available. We know the utility of a lot of these genes. Many healthcare systems have not changed the way they approach introducing these genetic and genomic insights into cancer care, into conversations. But everything that you just talked about, when we crossed paths, you talked about your vision then. And so when you announced it earlier this year, I got to tell you, that's why I'm telling everybody that I don't have a stake in this. I have to tell you, I was so impressed because I have talked to your colleagues for years and years, and we've really made no progress. What's the difference? How have you been able to stand up this type of program? And when we consider AI and tools like using our smartphones, where are you on pace to be in another 5 years?
I couldn't do anything without the support of a philanthropic community right here in DFW. You might say, how did you get this started? Because a lot of these tests, by the way, will have to be very clear, aren't covered by insurance. And some are not FDA approved as well. So remember I said at the outset, we're talking about a lot of the time research. It's maybe not prime time right now, but I told you 2 of the blood tests for multi-cancer will be on the market soon, but patients will have to pay out of pocket. That makes it a little bit more difficult for everyone in the country, right? Because you have a proportion of our society that can afford some of these blood tests and some that can't. But my hope is what we're trying to do is launch a number of these on clinical studies, where if you're on the study, you don't have to pay for the actual blood test. And we're trying to understand the anxiety these tests cause and the real-time patient experience and what people feel like when they're on these particular trials where they're getting blood tests. I think things will open up, but that's, outside of my control. The blood test for colorectal cancer is FDA approved. So again, people can talk to their insurance company. But this is where I'm saying, I'm talking about the next couple of years as things open up and we move away from a reliance on imaging to more biomarker testing from a blood or urine or cheek swab, okay? We were able to get our institute up and running from a large philanthropic donation by a gentleman called Mr. Jeff York. He's a great friend of ours here at Baylor Scott & White. He gave a large donation to get us up and running, and then we've been engaging with our community here in DFW to support us, and they've been great, and we're actually going to be fundraising even more to keep things going. So the initial launch of our institute was through philanthropic support. And now what we're seeing is industry becoming very, very interested in being part of this because we have a huge patient base throughout Texas. And if we're able to offer innovative studies to be able to understand the patient experience, the anxiety, as I've mentioned, how to operationalize new ways to detect cancer across large health systems, that's what America's waiting for. The FDA is wondering, okay, you may have a test, but what are the implications of the test? How long does it take to actually formally diagnose a cancer? Is there false positives? Is there false negatives? Is the anxiety in patients concerning? We're going to be studying all of those things through our new institute. I think the things that we'll be able to show our community won't just be about the efficacy of the test, will be about the patient experience. The way I explain it, we had a vaccine for COVID and half the country took it and half really didn't. We've got a fragmented healthcare system. And we need to understand if we now have new ways to diagnose cancer, who in our community wants this and who does not want this? How do we break down those barriers? How do we understand how we can democratize this new ability to detect cancer so everyone across our great country can benefit from this? That's what we're trying to study.
First of all, let me say, I really appreciate your candor, your transparency with the things that we're talking about, because some of the things that we're talking about are covered through insurance, some aren't, or in protocols, but that's okay. We want to give the information to those folks who are seeking it and to have those conversations with their care providers and their support team as well. So I appreciate that. We'll get you out of here on this. For someone who's listening or watching and they want to be proactive about their cancer risk, maybe they have a family history or they suspect something, what steps do you recommend, or if there's genetic tests or screenings they should ask their doctor about, but what are 3 practical tips for our viewers to help intercept cancer?
You hit the nail on the head there. Family history is important, for sure. We may not be able to prevent cancers in 2025, but we should empower ourselves with information to know if we're higher risk. So I think if you're a woman, for example, or a man, and there's a very strong history of breast cancer or of colon cancer, for example, talk to your doctor about could you have a genetic risk for one of these cancers. There's lots of other ones, but I'm just picking breast and colon right there. That's number 1. Number 2 would be to make sure once you hit the age for when your screening should start, if you're a woman or a man, whenever your age begins for mammography or colonoscopy, to make sure you do that, because I think too many of us let that go by the wayside and we don't jump in and start our screening when we're supposed to. So I think that would be important. Of course, this is the easy part, to try to not smoke cigarettes, to eat a healthy diet, exercise. We all know that that's important, but it's not so easy to do, but certainly the diet and exercise is key, and never smoking is key, and lower alcohol consumption, they would be important. But I think most people know that. The last bit is to watch this space about where we're moving. I've already talked to your group today about the new tests that are entering the market. I'm really excited about the future, because I think artificial intelligence, these computer programs, is going to now bring us even more into the future, where we're already seeing the ability to take large data sets and to maybe predict who's at risk, but just by information. So the more information we have, and so you might say, what's he talking about? Well, you've heard of patients who have gone to a hospital for 20 years and then they get diagnosed, they've got cancer. And everyone says, well, they went to that hospital for 20 years. Did they never predict anything? It's possible, that these new computer programs can start looking at information in ways that we haven't seen before. We're looking at now AI programs that can read x-rays really quickly. I don't think they'll replace radiologists in our lifetime, but I think they'll be a digital assistant to look at x-rays or CAT scans. Same thing with pathology. When you look down a microscope, the human eyeball can only see so much, but now we can start training these computers to look at all different components of our immune system in ways that we've never imagined before. And then the last piece will be bringing it all together. So if you could bring in family history, genetic history, even wearable devices. We all wear these Apple smartphones on our wrist. Environmental exposure, family history, medications, and start pulling it all in. Is it possible to develop programs that might be able to say, oh, we've got this patient in southern Texas that looks like they're high risk, or this man in East Texas or West Texas or wherever. That's where I think we need to start going. Let's start bringing all the tools that we have over the next couple of years to see if we can identify if someone is at high risk. Of course, if you've no information on someone, it may be hard to predict, but I think in the future, we're going to start having a lot more information on each of us. I've already mentioned these blood tests that I think will become more common, genetic testing through cheek swabs and so on and so forth. So again, my eye is on the future where we have large amounts of data, and I think we may be able to start helping our population by empowering them, by just telling them the computer or the data sets, flashing maybe red light here doesn't mean you got cancer, but can we get you one of these blood tests, or can we order a scan just to make sure? And then people aren't sitting at home not knowing that there may be an issue hidden in the middle of their bodies that they don't know about. Let's see if we can be more proactive on the war on cancer. Let's try to decrease that cancer mortality curve. And if the United States government ambition is to decrease cancer mortality by 50% over the next 25 years, we have to start bringing technology, and we have to start bringing new tests to our populations, and so that everyone can partake and not just a fragment of our society.
Absolutely fascinating. Dr. Ronan Kelly, Executive Director of Oncology at Baylor Scott & White Healthcare System in Texas. Now, Dr. Kelly, I hear your Irish accent. I don't know if you're a fan of Texas football, but the Texas Cancer Interception Center is probably the most Texas title you can have for football with an interception in the title.
I'm a huge Cowboys fan, yes. So definitely a big NFL fan, so for sure. And my friends are getting me more and more into college football. I didn't go to college here, but I've got 4 kids, 2 of them born in Texas, so I'm certainly learning more about college ball, but definitely a big NFL fan. Yeah.
Thank you for sharing what you guys are doing to beat cancer, intercept cancer, and for future generations, prevent cancer. Fascinating stuff. Thank you for being a guest on Genetics for Healthcare.
Thank you very much.
This is Genetics for Healthcare, a podcast for patients.